Thank you. Okay, folks, if you can still hear me, I'm going to start the webinar now. So that means participants can join, and the slides will be running until 6 o'clock when I and until we start the presentation. Sorry, start the event chaired by Satvir. Thanks.
Okay.
Right.
Hello everyone and good evening. So on behalf of St John's DermAcademy in London and the National Eczema Society, we are really delighted to welcome you to this evening's webinar. So the next hour's webinar will be, it's aimed at patients and the public, and our focus for this evening is on eczema itch. So you're going to hear from our expert speakers, and then at the sort of about halfway through our hour-long program, our speakers will be joined by an expert panel of clinicians and pharmacists and patient representatives who are here to answer all of your questions. So our team work in adult and paediatric eczema services, and much of the material will be UK focused tonight. Just a bit of housekeeping before we start. So please don't video or audio record or take photographs of any part of the next hour-long webinar. We are recording the event and we'll share this online after the event. And we're also live streaming the event on the National Eczema Society Facebook page. You can see and hear us, but we can't see or hear you. So if you'd like to communicate with us and ask a question, please use the Q&A function on Zoom, which you'll see at the bottom of your screen. And the chat function is disabled, so please don't use that. So stick to the Q&A. All of the questions can be posted anonymously. And we're really keen to hear from you. So as you're listening to the talks, if questions are popping up in your mind, please just share them. And we hope to get through as many as we can. And we'll certainly pick a representative section for the Q&A session. And feedback is incredibly important to us. So this is our 5th collaborative event between St John's DermAcademy and the National Eczema Society, and we're always working on improving it each time so that we can really sort of tailor it to your needs. So let us know how we've done at the end, and we will be sharing the QR code for an electronic survey through which you can submit your feedback. So the link will be shown on screen, and we'll also pop it in an email to you at the end. So without further ado, I'm delighted to kick off the programme and introduce Dr. Sarah Drummond. So Sarah graduated from Edinburgh University, and she is currently the Senior Clinical Fellow in Medical Education and Medical Dermatology at St John's Institute of Dermatology. So she spends half of her week doing St John's DermAcademy activities and half of her week working in across our medical dermatology services, one of which is our severe eczema clinic. So Sarah's sort of bringing together her experiences and expertise and giving us a good summary of why does eczema itch. So thank you, Sarah, for speaking today.
Thank you, Satvir, for that kind introduction. Hopefully you can see my slides okay?
Yeah, they look
Great.
good, thank you.
Okay, so for the next 15 minutes, I'm going to be talking about eczema and why it's itchy, what treatments we have at our disposal to help with eczema and itch, and looking to the future, are there any new treatments in the pipeline coming through? So first of all, what is itch? So it might seem like an obvious question, but itch is an unpleasant sensation in the skin, which leads to the urge to scratch or rub to relieve the sensation. And it's thought to be an evolutionary response. So if something touches the skin, such as a harmful irritant or poisonous plant or an insect, then this leads you to scratch and remove that irritant, and this is a protective response. But there's a number of diseases, whether they're skin disease or otherwise, that can cause a longer lasting chronic itch. And as you know, itch is a hallmark feature of eczema. And it's important to recognise that the sensation of chronic itch not only leads to the physical impact with scratching, disrupting sleep, but it also can have a significant psychological impact and affect the moods of people who suffer from chronic itch. So why is eczema itchy? Well, we need to think a bit about what's going on in the skin affected by eczema. So here we have the keratinocytes or skin cells in the most superficial layer of the skin. And these skin cells are bound together tightly to create a barrier to the outside environment. And they're a bit like bricks, which are bound together with cement made up of substances produced by the skin. And an important part of this barrier process is a protein called filaggrin. And filaggrin is important in causing these skin cells to change shape and become a compact layer. And filaggrin also breaks down into smaller molecules which help to draw in moisture and hydrate the skin cells so that they're plump and stuck closely together. So filaggrin is key for having a strong skin barrier, and this allows the skin to do one of its key jobs in preventing things like allergens and irritants from getting into the skin. And so if filaggrin isn't working properly, this leads to a weakened skin barrier, where more allergens and irritants can penetrate the skin, more water is lost from the skin, and it also leads to changes which make it easier for bacteria to stick to the surface of the skin. And we know that there's a filaggrin gene, and that this gene is faulty in more than half of people with atopic eczema, meaning that these people have a weakened skin barrier, and this contributes to their eczema. So what happens next? So we have our skin barrier, which is weakened, and this allows more irritants and allergens into the skin. It also leads to an increased bacteria on the surface of the skin, and this, as well as other factors such as genetics, climate, and the skin microbiome, play an important role in the development of eczema. And these factors then trigger the immune cells in the skin to set off a bit of a chain reaction of different chemical messengers. Some of these chemical messengers directly signal to nerves in the skin, which send itch signals to the brain. And importantly, these itch nerve fibers are different than the nerve fibers which are triggered by histamine. And that's why eczema itch doesn't tend to improve with antihistamines. Some of the other chemical messengers lead to a further reduction in the filaggrin that I mentioned, and also other changes to the skin barrier. And you can then appreciate that this becomes a bit of a vicious cycle. So the chemical reaction cycles again, triggering the itch nerve fibers, and this leads to scratching, which causes damage to the skin, and again makes it easier for allergens and irritants to get into the skin. And this drives what we refer to as the itch-scratch cycle that happens in eczema. However, the cause of eczema is still not fully understood, and there's more research happening all the time to try and fully understand what drives eczema and eczema itch. And this is a recent study from Harvard University that's shown that Staphylococcus aureus, which is a bacteria commonly found on the skin of people with eczema, produces a chemical, and this can directly trigger the itch nerves. And the authors of this study think that this discovery might be a future treatment target to help treat eczema itch. So at the moment, how do we treat eczema itch? Well, the main way to improve itch and eczema is to treat the eczema and stop that chain reaction of events that's driving the eczema and driving the itch. And this means that the person's less likely to scratch, allows the skin barrier to heal and recover, and breaks that itch-scratch cycle that we talked about. So what treatments do we have at our disposal at the moment? Well, we tend to start with topical treatments. So emollients or moisturizers are really important in hydrating the skin and improving that skin barrier to protect the skin surface from the allergens and irritants coming in from the outside. And Julie's going to talk a bit more about that in her presentation. The rest of the treatment for eczema is focused on treating the inflammation in the skin and stopping that chain reaction triggering the itch nerves. So topical steroids is often our first line treatment for eczema, and these act directly on the skin to reduce inflammation and allow the skin to heal. And it's important to note that topical steroids come in different potencies or strengths, and it's important to use the correct or appropriate strength depending on the site of the eczema and the severity. So for example, the skin of the hands is much thicker than other areas of the body, and so you're likely to need a stronger or more potent steroid to treat eczema on the hands or feet compared to more delicate areas like the face. And similarly with severity, if you've got very severe inflamed eczema, you're likely to need a higher potency or stronger steroid to treat this than milder eczema. It's also important to apply the correct amount of steroids, and the way to tell this is to use fingertip units, which is what this diagram here shows. And a fingertip unit is if you squeeze out a strip of your steroid cream or ointment onto your fingertip from the crease at the fingertip to the end of your fingertip, that is one fingertip unit. And that's then enough steroid, cream or ointment to treat 2 handprints worth of skin. And there's a really helpful information leaflet on the National Eczema Society website that gives you a bit more information about that. So if your GP or doctor is prescribing topical steroids for you, it's really important to make sure you know that you've got the correct strength for the site that you're treating, and you know that you're applying the correct amount and the correct frequency. And we know that using steroids once a day is just as effective as using them twice a day, but once a day is less likely to cause side effects. So we tend to just recommend once a day use of topical steroids for a short burst of a week or maybe 2 weeks, and then aim to reduce down or stop using them depending on what's recommended by your doctor. So it's really important to have clear instructions so you know what you're doing, so you're using these safely and the way that's going to help treat your eczema. I've also mentioned topical calcineurin inhibitors here, and that's treatments like Protopic, which is tacrolimus, or Elidel. And these are other creams and ointments that are non-steroid based, but are also anti-inflammatory and can help to treat eczema. And these are really useful for more delicate areas of the skin, like the face or skin folds. And these are a really helpful alternative to topical steroids. So what next? If you've been using your topical treatments appropriately and you're not able to reduce down how often you're using the steroids, or you're using large quantities, or your eczema is still active and disrupting your sleep and having an impact on your quality of life, then you're likely to need further treatment and referral to dermatology to see what else we can offer you. And luckily, there are lots of treatment options available. So phototherapy is often what's used next, and this is a form of light treatment, usually ultraviolet B light treatment. And this can be a really helpful treatment in some patients, particularly if people notice that their eczema improves when they're on holiday in sunny weather, then phototherapy might be a really good option. It's important to note that the phototherapy is different from going for a sunbed, and we would always recommend against going for sunbeds. The reason being that these are not monitored, they're not regulated, and they're essentially unsafe and associated with an increased risk of skin cancer. Whereas the phototherapy used in hospital is monitored closely, prescribed by the doctor who's checked your skin, and administered by highly skilled nursing staff who make sure that you're getting the correct dose over the correct amount of time. So that's a really helpful treatment option to have. Other treatments that we have available are called systemic treatments, and these are given either by tablet or injection. And the two that I've listed here have been around for a good number of years and can be very helpful in treating eczema. They both work by dampening down the inflammation in the skin that's driven by the immune system and the immune cells in the skin. And these are prescribed by the hospital, so your GP wouldn't be able to prescribe these. And it's important that they're monitored to make sure that you're getting benefit from the treatment and that they're not causing side effects. But these can be really effective treatments for eczema. And eczema treatment has really evolved over the last few years, and we now have several newer treatment options which are a bit more targeted at treating eczema. And in the UK, these can be considered in people with moderate to severe eczema who haven't responded to these other treatment options that I've mentioned. And they're broken down broadly into two categories. So we have biologic medications, and these are dupilumab and tralokinumab, and these are given by an injection into the skin. And they work by targeting specific parts of that chain reaction that I mentioned earlier. So they are blocking that pathway and therefore disrupting that cycle and allowing the skin to heal and reducing that vicious itch scratch cycle that we mentioned earlier. JAK inhibitors, there's 3 of those that are available for eczema, called baricitinib, abrocitinib, and upadacitinib. These are tablet medications that work a bit more broadly than the biologics, but similarly, they reduce the inflammation in the skin via their action on the immune system. And what's been great is it's such a development of new treatment options for eczema over the last few years that we now have these available to use in the NHS. It's important to mention that no matter what stage of the pathway you're in, to continue using your moisturizers to support your skin barrier, avoiding any triggers that you know flare or worsen your eczema, And also look out for any signs of infection that might be causing a worsening or flare of your eczema. So if your skin becomes painful, weepy, or crusted, you might need specific antibiotics, or if there's the cold sore virus can sometimes cause a flare of eczema as well, and that would need antiviral treatment. So it's important to look out for these signs in case you need different treatment as a short-term thing to settle a flare. A lot of people try antihistamines to see if these will help their itch and eczema. However, as I mentioned before, the nerve fibers that are triggered by the inflammation, the lights have gone off here, triggered by the inflammation in eczema are not histamine driven. And so we don't recommend antihistamines to treat eczema itch. Some people find sedating antihistamines can be helpful to help them get to sleep at night time, but these aren't actually treating the eczema or treating the itch. It's more just allowing you to get sleep. And that's not something we'd recommend as a long-term option because they can have side effects if used long-term. So what's on the horizon for eczema treatment? We've had lots of new treatment options become available over the last few years, but there's more in pipeline. So there's been a development, or there's a lot of research ongoing into some new topical treatments that are non-steroid based to treat eczema. And I've listed 3 here. These aren't yet available for use in the UK, but some have been developed to treat other skin conditions and are now being investigated to see if they can also be used in eczema. And Crisaborole has been approved for use in the US and Australia and New Zealand for treatment of eczema. So it's really exciting that some new topical treatments are coming through, hopefully in the next few years, that can be used to treat eczema. I mentioned the biologic treatments that we have already, and there's more research ongoing into other biologic medications. So nemolizumab that I've listed here specifically targets the chemical messenger that triggers the itch nerves in eczema. And so it's being used in the United States and some other countries to treat nodular prurigo, which is a kind of itchy condition, and it's also being investigated for its use in atopic eczema. So that may well be something coming through soon. And lebrikizumab is another biologic medicine which has been developed to treat eczema with promising results in clinical trials, and hopefully might become available in the UK in the next year or so. So that was a bit of a whistle-stop tour of eczema and itch, but the main take-home messages are that itch and eczema is caused by inflammation in the skin sending itch signals to the brain. And so to treat the itch and eczema, you have to treat the inflammation in the skin. I've outlined the stepwise approach to treatment, and if eczema is not controlled with topical treatments from your GP and it's still disrupting your sleep and impacting your quality of life, then it's really important to ask for help and a referral onto dermatology. There's a range of treatment options available at the moment, but there's ongoing research and new treatments in the pipeline that hopefully will be coming available soon. And I just wanted to mention that the National Eczema Society and British Association of Dermatologists both have excellent information leaflets available with more information on these treatment options that I've mentioned. Thank you.
Thank you so much, Sarah. That was brilliant. Really good overview and very comprehensive. I'm not going to ask questions yet because we're going to save them for the Q&A. There's lots that have been coming in. So thank you very much to everybody watching and listening for all of your interaction and sending through all your questions. So Sarah, we will see you shortly, but it's my pleasure. Thank you, Sarah. It's my pleasure to welcome Julie Van Onselen. So Julie's going to pop on screen now. So Julie is a dermatology lecturer practitioner. Hi, Julie.
Hi.
And with extensive experience in clinical dermatology education and training. Julie is a clinical nurse advisor for the National Eczema Society and a medical advisory board member. And actually Julie works on the helplines for the National Eczema Society, so and helps to update the public information. So Julie brings a wealth of experience, and it's fantastic to have you here, Julie, telling us all about top tips for managing eczema itch. Thank you.
Thank you very much for your kind introduction, and good evening to everybody out there. Thank you so much for joining. It's fantastic to be able to talk to you tonight and share experience, really. I'm very passionate about eczema and eczema care. I'm very passionate about making things better for patients and their family, hence why I've been working with the National Eczema Society as a volunteer and now as a member of staff for, I think about 30 years, so a long time. Anyway, what we're going to talk about tonight and what I'm going to try and help you with is how to understand and cope with and control eczema-related itching and scratching alongside eczema treatment. So this really is really important, because when we think about itching and scratching, as I say, it's the key symptom of eczema. As Sarah said, it's the hallmark of eczema, and I think that's a really good way to describe it. It can range from intense, distracting irritation or tickling, but generally at every stage of eczema, whether your eczema is flaring, which means it's red and inflamed, or whether it's quiet and skin is dry, itch is a part of eczema. It's just worth saying the medical term for itch is pruritus, so we should really talk about the itch and the scratch, but sometimes people talk about pruritus, just so you know that terminology. And of course, itch is the symptom and the sensation, but scratching is the response to the itch. So divide your itch and scratch. And constant scratching will lead to worsening eczema. It's very hard to tell someone with eczema not to scratch, but worsening eczema can also lead to roughening, and we call that lichenification, which is thick and leathery skin. And this obviously is related to the itch-scratch cycle, which Sarah talked about. So recapping what makes eczema worse, there's another nice diagram here of the skin barrier. And I can't stress that enough. I sometimes say very simply, dry skin is always itchy skin. Also, itchy skin and intentionally itchy skin means eczema's flaring. So eczema flares, and eczema means that skin will be itchy, and if eczema is not being treated, it will be more itchy. Environmental triggers, I'll talk a bit more about that. And the itch, scratch, damage cycle, as I say, can also have a psychological element and an element sometimes of habit, which again is nobody's fault. Now, when I talk to people about eczema, I'm quite a simple soul. I like to say, you know what, eczema is rather like the sea. It's completely unpredictable. Sometimes your eczema will be very rough and the waves will be crashing down, and that's when you have inflammation and you have sore skin, scaly skin, weepy red skin. And then the eczema will be treated or will have a quiet period, but then the eczema will come back. So it's really important that itch can relate to stages of eczema, and in dermatology we call that the acute stage, the subacute stage, and also the subacute stage, moderate, and often itchy is the chronic stage. So eczema goes through these stages. Eczema is a long-term condition. Sometimes you can have eczema and go into remission, and it can not be so bad, but it can certainly come back. We see this a lot, actually, quite often with people who've had childhood eczema, and it comes back as an adult, but it's the long-term nature of eczema. But you can see itchy is in red because that really is the hallmark symptom. Now, environmental triggers are important to talk about because, as Sarah rightly said, these are very much part of eczema severity and itch. And when you have eczema, you've got to try and control your triggers. I work with the PCDS, the Primary Care Dermatology Society, and our approach to eczema is ABC, which is avoid irritants, bland emollients, and control inflammation. So avoiding irritants is hard. Some people have a lot of irritants, which may drive their eczema and drive the flares and the itch. And for some people, it may actually be an allergy. So we're not talking necessarily about allergy in detail tonight, but just to be very top line, a lot of people would like allergy tests because is that making their eczema worse or more itchy? And actually, in truth, if everybody did have an allergy test of eczema, everybody probably would be allergic to two things on this diagram. I always say one inside the house, that's the house dust mite in furniture and bedding, and one outside the house, and that's pollen, and that can be worse at various times of the year. So they're almost universal. Universal irritants are heat, soaps and detergents. So actually washing in eczema is very important, but always with an emollient, never with water alone, and don't use soaps or bubble baths. Infection obviously is a trigger. That is part of eczema itself. We've already discussed that. And of course, you're not allergic to the winter or the summer, but season and seasonal variation can make a difference. Allergies are to food and generally in children under 2, and also to pets are as well. People fret about washing powder and what to use, and sometimes, again, you find one to suit you. But in truth, it's not what you wash your clothes in, it's what you leave on your clothes. So it's fragrance, fabric conditioner, and also hanging on the line with the pollen. And of course, we know eczema has a huge psychosocial effect and is terribly distressing and upsetting, not only for the person, but for the family as well. So stress can be a driving force. So actually addressing quality of life and psychological factors is really important, which leads us on to how itch, scratch, cycle can have psychological elements. As I say, due to itch, but also sometimes habits can form where the skin is constantly scratched or rubbed, and it can become a habit. So really, we need to try and break that habit. And obviously, patients with stress will often experience worse symptoms as well. We know from a study that psychogenic stress, so if you're stressed, it will exacerbate itch, and the itch, scratch, anxiety cycle can form. And 64% of adult patients in this study have reported a stressful life event before their eczema actually flares up. So habitual scratching is scratching with eczema over time, which becomes a response not only to the itch, but also to habit. And if you are, your mental state means that you have some anxiety, you may go to scratch. This happens in children as well. Sometimes children will get very upset and they'll sit down and use scratching almost as a tool to shed frustration maybe, or also maybe try and get attention as well in the nicest possible way. So actually, habitual scratching means the management of eczema can be less satisfactory, and factors that drive scratching need to be addressed. So we see a slightly different circle here, and here we're bringing in the itch due to dry skin and inflammation, eczema flares, but scratching can also relate to itch, but also it can relate to habit and mental state. So in a minute, I'll tell you one sort of behavioural technique which is quite useful to help with habitual scratching. So here's some top tips for you to try and reduce itch alongside eczema treatment. It goes without saying, emollients, emollients, emollients at every stage, and treat the eczema. It's really important to use your treatments, your topical steroids for your short bursts. If you need, if it doesn't work and you need other treatments, please ask to be referred. As Sarah said, there is so much out there now, and sometimes eczema gets to a point where it is very severe and the steroids don't work as well, and you do need to be assessed. Environmental measures, as I say, are reducing avoiding triggers, reducing nighttime itch, and habit reversal. So a little more on emollients. Again, we've seen this diagram before, but emollients treat dry skin. Dry skin is itchy skin. There are lots to choose from. There are some designed with anti-itch ingredients that are sometimes helpful because they're cooling and they generally contain a menthol. I'm not going to mention any products because I don't want to advertise, but the whole point is you need to find an emollient that really suits you, the one you like using. It will relieve the itch because emollients are your anti-itch treatment, and it's really important to have a daily bath or shower and cover yourself in emollient, careful of slipping before you get in the bath and shower, pat dry, apply more emollient, or if you're treating your eczema, apply steroids, wait 30 minutes, apply emollient, because the emollient is constantly repairing the skin barrier, and the damaged skin barrier also drives itch. No irritating ingredients or fragrance. A really simple tip, really thing that a little thing can make a big difference is don't rub in your emollient. Rubbing immediately starts a scratch cycle and an irritant, and it also can push the hair follicles in and cause folliculitis. So if you just make applying your emollient a really soothing experience, dot it on, stroke it downwards, and smooth it on in long strokes, just trying to demonstrate here. Now, I think children need to learn to use their emollients as they learn to use knives and forks. I always say it's part of childhood development. You can use reward charts, and children should actually learn to apply their own emollient, whereas the parents obviously should apply their treatment. So I've done another little itch scratch damage cascade cycle, because actually the itching and scratching can lead to damage. And actually people worry about steroid effects in terms of steroid skin thinning or damage to people's skin, but I've seen far more damage by eczema not being treated and people scratching or damaging their skin and causing scarring that way. So remember, emollients come in at every stage to prevent and treat itch, dry skin, and alongside eczema treatments, help reduce eczema flares. I've already mentioned triggers, but certainly identifying your own triggers and avoiding triggers will really help to reduce your itch as well. But sometimes that can be individual. Sometimes you do need help from dermatology. You may need some allergy tests, and allergy and eczema go alongside. And for some people, that can be a major part of their treatment and investigation. Or for other people, it's the irritancy of things like soaps, detergent, and the weather that might be more of a problem. It's very individual. Nighttime is a really difficult time. Another useful study in adults showed that scratching occurs in the earliest stages of sleep. And wakefulness often occurs after a bout of scratching, rather than the frequency of scratching in their sleep. So I think a lot of you will know who have eczema that you're very restless often at night. Also, people with eczema overheat at night, so keeping the bedroom cool is really, really important, about 18 degrees, and using light tog duvets or even separate duvets if you're sleeping with a partner. We've talked about antihistamines, we've talked about triggers, avoid hot showers and baths, so always a short, sharp, tepid bath, and use natural fibres, avoid rough seams, and cut out any labels of bed clothing. Sometimes bandaging and wet wraps can be really helpful as a damage prevention, particularly for children. And make your bedroom a really relaxing place. Avoid screen use, keep it cool, because actually trying to enhance sleep is really important. So the combined approach, which is using habit reversal, is very useful behavioural approach to help stop scratching. I'm describing it very briefly, but you can certainly go to the atopic skin disease site where it's explained in detail. So you're trying to move from scratching being an unconscious behaviour to realising in your consciousness how damaging it can be. You can use a hand tally to almost record how often you're scratching, and you will be surprised. Sometimes you are scratching or touching your skin several hundred times a day. And then habit reversal involves moving into a conscious state of understanding scratching and using distraction techniques. But it's combined because it's not an alternative. We need to keep treating the eczema. So my take-home messages are: dry skin is always itchy skin. Treat eczema first and foremost for itch. Reduce triggers. Ask for help and referral if eczema is not controlled, because this means your eczema is more severe and you need different treatments. The Eczema Society has useful information and fact sheets, and please do join St John's Academy for more public events, because keeping yourself informed is really important when you have eczema or any chronic disease. So thank you very much for listening.
Thank you so much, Julie. That was incredibly useful, packed full of really helpful practical advice. Thank you so much. So if you stay on screen, Julie, and stay with us, and then I'm going to invite Sarah back and the rest of the panel. And I'll just give brief introductions for the rest of the panel. Thank you everyone for your, to all of our listeners and watchers for your participation. We've been looking at all the questions as they've been coming in. So let me just quickly go around the room just to introduce. So we have, first on my screen is Dr. Alpa Kanji. So welcome, Alpa. So Alpa's currently undertaking a senior fellowship in paediatric dermatology at St John's Institute of Dermatology. Alpa is a scientist by background and did her PhD in bacterial genetics at the University of Cambridge, and then trained in medicine and dermatology in London. She also teaches habit reversal, which Julie sort of touched on there. So great to have you here, Alpa. Thank you for joining. next to Arlene. Welcome, Arlene. So Arlene Maguire is our specialist pharmacist who works across dermatology and allergy at Guy's and St Thomas's. Arlene brings a wealth of experience in pharmacy, medicines management and prescribing, and has a particular specialist interest in inflammatory skin diseases, and has been involved in updates of guidelines for example, biologic treatments in psoriasis. So thank you very much, Arlene, for joining us today. And finally, Andy, welcome to Andy. So Andy Proctor has been pivotal actually in bringing this event to us, and works very closely with us in DermAcademy to bring these collaborative patient and public engagement webinars to life. But Andy's most of the time is spent as Chief Executive of the National Eczema Society. And as I'm sure all of our attendees will know, this is a charity that provides information and advice for people with eczema and their families, raising awareness of the condition throughout the UK, supporting research and campaigns for better care. Andy's also actively involved in a number of research efforts as well. So thank you. Right, so just to begin the evening, so I'm going to start off actually with Alpa, if that's okay, and just to sort of shine a light on children in particular who might be suffering from it. It's a very direct, very important question. What is the best approach to tell my child, encourage them to stop scratching? Where would you start?
Yeah, I think it's a very important question. I think first of all, telling a child not to do something inevitably means that they'll do more of it. So I think we very much encourage parents and carers to use very positive language. So rather than encouraging, telling them not to do something, encouraging them to do something else. So I think, the first thing is awareness. Noticing when your child scratches is key. So for example, when a child is undressed, you will typically see that most children start scratching and aiming for their skin. They might be scratching when they're upset and distressed. So I think awareness is key, noting what are the particularly scratchy times. And then I think the next step is to devise strategies. So strategies to deal with those times. For example, distracting them, giving them something to play with, keeping their hands busy, and making that a positive thing. So rather than saying don't scratch, giving them something else to do and making that a positive thing. I think that can be helpful. And I think depending on the age of the child, so if it's a young child, you can teach them to tap the skin. So that way they are tapping the skin sort of like that instead of scratching it. If they are older, then you can teach other techniques like maybe clenching fists and counting to 10. So I think it's about awareness of when they scratch, noting that, and then devising sort of tactics and strategies to help them change their behavior, but in a very positive way.
Thank you. That's really helpful. And in your experience, what happens with age of this itch with eczema? So what tends to happen over time?
So I think when children are very young, you find that they do scratch in response to feeling itchy, but also when they are crying, distressed, sad, they will eventually, if it goes on for long enough, start sort of clawing away at their skin as a kind of response to being upset. With age, there is an increase in awareness. So older children are much more aware of when they're scratching, and they're much more able to kind of, once they have their awareness, they are more amenable to sort of develop tactics and strategies of their own because they're aware of when they're scratching. But I think with young children, particularly holding their hands and kind of, more sort of more, the parents need to much more intervene. Whereas older children, once they're aware, can kind of be taught, to devise their own ways effectively.
Thank you. Thanks, Alpa. Coming back to you, Julie, you meant, and picking up on the sort of habit reversal side of things, how can patients practically find out about this and do it and tap into these sorts of techniques? What are the different routes into that knowledge?
Well, unfortunately, in the UK, it would be great if we had more psychologists in every sort of big department, and obviously at St John's you have that, and you have Alpa already doing habit reversal, and several other practitioners, and I did it myself in primary care for 15 years. So it is a technique that is useful to be able to do with somebody trained in the technique. But saying that, I'm not actually sure if it's still in print, but if you go to Christopher Bridget's website, there is some tips about how you could maybe self-teach awareness and habit reversal. So I would like to see, personally, I would like to see habit reversal increasing in dermatology departments and being offered as a strategy alongside, because I do think it's a technique that's well researched and is very important, and I just wish it was more available for all. So a bit of searching around. Local departments may offer it, but as I say, just have a little search around and see, because there are ways of self-managing as well with it.
Thank you. Thanks, Julie. So I'm going to bring Arlene here. So picking up from Sarah's talk, Arlene, about all of the new treatments, particularly the injection treatments, the biologics that are now available for eczema. Could you tell us, first of all, a little bit about sort of the decision making that sort of goes into who these injections might be available for, number one, and then secondly, can people get the injection, say, privately or not in the UK without trying some of the other tablet treatments first?
Yeah, sure. So within the UK, we've got an independent body called NICE, and it's their job to really assess, the evidence and the normal treatments that for a particular condition, and weigh up the costs, all of that into like a very in-depth decision-making process, and then they decide whether to either recommend it for the NHS or not. So I think with our injections, it's around 5 or 6 years ago now when we got the first injections through for eczema, which were approved by NICE. And since then, we've obviously learnt a whole lot more about them by using them in practice. So typically what happens is, NICE would say they're for moderate to severe eczema in patients who have failed one or more what we call standard systemic therapies. But patients sometimes may be contraindicated, so they might not be able to have those standard therapies, or there might be other reasons why we may have to move on from that stage. So I would say that it's not definitely a blanket rule, and it's obviously always good to be referred to a dermatologist to be assessed, and they would go through all these processes in deciding the best therapy for you. And there are local pathways and things in development where there may be different guidelines in place. So I think NICE is the overall advice, but then locally we do have different pathways for accessing treatments. Privately, yes, you can access these treatments. I mean, I would probably say they're very expensive. So in the NHS, we get access to sort of different pricing, because we're obviously buying them in bulk, but privately, you could be looking for a biologic, could be in the range of sort of £10,000 to £15,000 a year. So they are very expensive treatments, and not something that everyone could manage privately. They're usually refrigerated and a bit tricky to access that way. So that there's a few potential barriers privately, but you can always approach that and see. And then outside of the UK, typically these drugs tend to get licensed and approved in, for example, the US first, and then they kind of come through to Europe and us. So some of the treatments are available there, and again, they have different access schemes and insurance systems for accessing those treatments. So it's a bit of a mixed picture, but I think we would always advise going through your GP, getting referred to a dermatologist on the NHS, and having your eczema assessed for all the different treatments we can offer. Absolutely.
So it very much starts at your dermatology clinic review when, that thinking begins with, obviously, depending on the assessment, how the dermatologists assess. But yeah, so absolutely, I think as you say at the end, if you're concerned, just to get that referral through to a hospital dermatologist. Thank you, Arlene, that's really helpful. I'm going to cycle back to you, Alpa, because there's an interesting question going back to children with eczema, swimming and eczema, which of course, you know, is very much all schools are now encouraging and swimming. And so what would be your advice with regards to your child going swimming if they've got eczema?
Yeah, I think it's really important that, you know, children continue the activities that they enjoy, and have sort of, you know, their eczema not disrupting life as much as possible. So I think it's important that children learn to swim if they enjoy it. What we normally recommend is using a barrier ointment usually. So when they're in the pool, the chlorine can irritate skin, which is broken and sore. So we recommend using a greasy, sort of very plain ointment. So there's lots around, but just a barrier, and that greasy ointment will form a sort of barrier between the skin with eczema and the chlorine, so it will prevent the skin from becoming irritated. And that normally, you know, most children find very helpful. Also, when they finished swimming, to have a shower and then to apply their emollients and other creams as needed. So yeah, that tends to most children can go swimming and find that's very helpful.
Great, thank you very much. Can I also ask a question, interesting question about eczema and food allergies? So sometimes eczema may be related to food allergies, particularly in childhood. How does this influence management, or does it in fact influence management of the eczema itself?
Yeah, so food allergies is a really complicated area. And we do sometimes, not always, find that children, particularly younger children who are very, very you know, severe eczema that doesn't seem to be responding to the normal treatments, there may be a food kind of allergy component to that. Now, this is not the case for all children with eczema or adults with eczema, so it's just a subset, okay? I would always advise someone who is concerned that this might be the case to kind of pay attention if they think particular foods might be making things worse, to seek advice, so to see their GP, their dermatologist, and to get referred to an allergy doctor, rather than to start sort of self-excluding foods, because obviously, you know, a growing child needs all the nutrients, and it's important that food groups are not excluded. But I would also suggest keeping a food diary. So if you're noticing that your child's eczema is worsening when they're having particular foods, that's always worth noting. If you're finding any other symptoms, so if they're having tummy pains, if they're having diarrhea, if you're noticing anything like that after eating particular foods, then it's very important to note that down. But an allergy appointment with an allergist will hopefully, you know, if they think there is a suggestion that there is an allergy to food, then there'll be testing and sort of investigations done. So it's important to get a proper diagnosis rather than to self-diagnose and exclude foods.
Absolutely. Thank you very much. So question to actually anybody who's able to answer. So can emollient creams be used as a wash in the bath or the shower?
Yes. Shall I answer?
Yeah, please do. Please do.
Yeah, no, absolutely. So we do encourage that. We try and keep things simple for people as well. So people don't want to have 10 different products on their bathroom cabinet or whatever. So I think if you've got a good moisturizer that you're using, you can absolutely try that in the bath or the shower as a wash as well. Sometimes the really super greasy ones obviously don't work as well. So things like 50/50 paraffin ointment are much more tricky to use. But definitely the cream-based ones work well in the bath or shower. And there may be certain particular products we advise people to use in the bath or shower occasionally if there's infection on the skin or other things we're trying to control. But as a general gentle wash, I think we would say yeah.
Absolutely.
Julie might have more there, yeah.
Anything to add to Arlene's summary?
No, I think that was a very, very sound and sensible summary. I think when you wash, just always use emollients with hands in the day. It's worth just decanting your emollient into a little pot and taking it round with you, and maybe children at school, because as soon as you sort of put soap on your skin or use harsh washes, you know, you can go 3 steps back. So, you know, emollients with washing at every opportunity, and you know, as I say, just generally trying to use your emollient, I say, as a 2-in-1, you know, a moisturizer and a wash. We have a very good fact sheet, emollient fact sheet, the Eczema Society, and it explains how to wash with emollients. So if you go to eczema.org, you can access that fact sheet.
Fantastic. That's one to look up. Thank you very much, Julie. Andy, I'm going to come to you now. So we've had one question on an area where there's, I mean, it's emerging as an important area, and certainly an area where we need more knowledge and more research. So it's good that awareness is improving. But do you have any advice on treating topical steroid withdrawal, Andy?
Sure, thank you. Topical steroid withdrawal is complex, and we've still got a lot to learn. It's hugely frustrating. There's relatively little research into the causes, symptoms, and treatments. And you know, there's a lot of discussion and awareness on social media, particularly about topical steroid withdrawal. The symptoms that people have can be extremely painful and distressing as well, so it can be very difficult for people. We absolutely understand that. I think our advice would be to speak to your doctor and your or your dermatologist if you have concerns about using steroids and the side effects, potential side effects. They have to be used in a certain way to make sure they're used in a way that's as more safe and more effective, obviously. So that's really important that you follow the guidance as well. But there's still a lot we don't know. And as I say, we do suggest that you speak to your healthcare professional. National Eczema Society has been trying to push the knowledge and understanding in this area, and we've worked with the British Association of Dermatologists and also the British Nursing dermatology nursing group to produce some updated guidance on topical steroid withdrawal, and that's on our website now. That was produced just a couple of weeks ago, the updated guidance, and we also have some quite extensive FAQs. So I would suggest people look there to try and get and understand more. But it is an area that needs a lot more research. Thank you.
Thank you, Andy. And I mean, thank you to the NES for everything that you're doing as well to raise awareness and to push research into the area. Thank you. So there's a question about menopause and eczema. Sarah, would you be able to comment on how menopause affects eczema, and any potential research that there might be into that?
So yeah, so around the time of menopause, your hormones, estrogen and progesterone, drop off. And we know that estrogen does have effects on the skin, and with lower estrogen levels, your skin can become more dry, and also you can have changes to the microbiome of the skin, which is the kind of the normal bacteria that live on the skin. And so people have observed that you can be more prone to having dry skin and eczema after the menopause. And we know that eczema kind of can vary throughout people's life, but potentially it can increase after the menopause. I think this is an area that probably needs a bit more research into what we do about it, and whether you know, HRT, which is used to treat the menopause, has any impact on the skin. I'm not sure about that, or how much is known about that in general. So I think it's an area that needs more research. But if you're having menopausal symptoms, then I would definitely see your GP. And we know anyway, as people age, their skin can become drier, and you're more likely to need moisturizers anyway. So that's an important step, as we've mentioned already.
Thank you. Thanks very much. And I think we might just have time for one quick follow-up. Alpa, back to you about allergy testing. Someone said, is 5 years old too young for allergy testing? So in other words, are there any rules about the minimum age at which allergy testing can be done?
No, 5 years old is fine for allergy testing. I think I would, you know, if there's a suspicion, I would definitely encourage the parents to take the child to see a pediatric allergist. I mean, there's different types of allergy tests. So there's a blood test that can be done. The results of the blood test are not, they're sometimes quite difficult to interpret. So sometimes there's skin prick testing done as well in conjunction, which means that there needs to be a skin that's sort of clear of eczema where those tests can be done. But, you know, a child can have both of those things at age 5 and even slightly younger. So I think it's always worth discussing with the doctor. as to whether a referral needs to be made to a paediatric allergy doctor.
Thank you. Thanks very much. And a very final question, it's about side effects from medication. So what should somebody do? I mean, maybe Alpa, we start with you, and Sarah and Julie, Arlene, please chip in. What should I do if I'm worried that I'm suffering from side effects from a tablet or injection medication that I'm taking for my eczema?
I'm happy to start. I think, you know, it's important that if you think you're having a side effect, to speak to the doctor that's prescribed it to you as soon as possible, you know, and to find out if you can, you know, get some advice over the telephone, or if you can be seen, because obviously there are different types of side effects. Some are serious and some are not so serious. So it very much depends on the medication that you're using. So I would always get some medical advice as soon as I could.
Absolutely. Thank you. Julie, anything to add just from your experience on the helplines at NES? Is this sort of the questions like this come? Oh, you're muted, Julie.
Yes, it's quite common. And again, I always say exactly what Alpa said. You know, if you're having biologics or immunosuppressants, you need to contact your department. And often the nurses actually are very involved in monitoring as well. So often there's more than one person to contact. As far as sort of topical medications is concerned, again, you know, any side effect you should report back to whoever's prescribed it. So generally with topical, it would be in primary care. But I think it's important not to just not to get worried, because you know there's always going to be options to perhaps change you to something else, but the prescriber really needs to know, and they need to reassess you.
Absolutely. And sometimes it can be a dose thing. So yes, it's all about starting that conversation, but going to the doctors and the nurses who have given the medication and who are looking after you. Okay, thank you very much. And thank you so much to everybody for their questions, everyone listening and watching. And thank you so much to the panel for your brilliant answers. You've sort of equipped everyone with a lot of knowledge and information. Thank you. So just to close, I'd like to hand over to Andy because we're going to do a quick poll to see how we've done. Andy.
Lovely, thank you. We just want to ask you 3 questions, if that's right, the quick fire questions, just to see how you found the webinar today. So this is the first question. If you can just answer yes, no, or maybe. So do you feel better able to manage eczema itch having attended the webinar today? So just I'll give you a couple more seconds. Brilliant, thank you. And so we've got our next question is so do you understand more about eczema itch? So do you understand more about eczema itch having attended the event today? Lovely. And then one final one. Sorry, the last one's not loading for some reason. It was, would you recommend the webinar to others? So perhaps if you give a thumbs up or a love sign or something, one of the reactions just to say, then that would be really interesting to see. Thank you. Oh, that's brilliant. Thank you very much. We really appreciate it. Thank you.
That's fantastic. Thank you so much. So thanks ever so much, Andy. So just to add that there will be a feedback survey. QR code will be flashing up in a moment, and the link to the survey will be in your email inboxes very shortly. So please fill it out and please share ideas for future topics that you'd like to be covered. So eczema itch came about from feedback that we've received on previous webinars. So please let us know other topics, and we are planning to deliver the next webinar later on in the year, in the autumn. The recording of this evening will be available to view via the National Eczema Society website, and also on the Facebook page of the National Eczema Society website. So so keep an eye on that one. And yeah, that's it for this evening. So thank you so much everyone for joining. Thanks so much to our expert panel for making today such an informative evening, and we look forward to seeing you again. Have a good evening. Thanks very much.